and she's a member of the steering committee of the Swedish Fracture Register. Well, please.
Thank you. I thank the FFN for this kind invitation, and most of all for putting this very important topic on the agenda. I'm not here to answer this question today. I can just give you my point of view from the Scandinavian corner of the world. But I hope that there will be some time for discussion when I'm finished, because this is very debatable. I'm an orthopedic surgeon, as you heard. I'm a researcher, a registered co-worker, and a lecturer. I would like to talk you through how we define the fracture that we are talking about, how many that are actually treated non-operatively, and why we choose that option. Some ethical aspects, the importance of understanding the patient's course of life, which outcome to expect, and how healthcare should be organized to provide a decent non-operative treatment if we think that's the proper way to go. Non-operative treatment can be a good option in very stable fractures, but non-operative treatment can also be based on patient's characteristics. We often talk about the patient that is non-walking in an acute life-threatening condition or in palliative care. And I would just like to stress that I'm not talking about these fractures today. But fracture stability do play a role, because in a stable fracture, it's much easier to abstain from surgery. But the more unstable the fracture is, the more eager we surgeons are to provide surgery in order to relieve the pain and make mobilization possible. So what I'm talking about today is that frail patients with an unstable fracture that normally should be treated surgically. This is a tricky one. It's very hard to find true numbers of how many patients that are treated non-operatively. It can vary between less than 2% and up to 15% in so-called developed countries. A Scottish paper talked about an increase. A Canadian paper talked about a decrease. Medicare population in USA could be 6%. Estonia, very good demographic papers there, talking about 10%. Kazakhstan, 25%. But as you see, very few papers out there actually telling us how many we do treat non-operatively. Then the reasons for doing so are also very hard to sort out, and I'm very, very grateful towards Lynn McNichol and Ian Moppet, who shared their important report with me. And I know that you have a good session. Yesterday I had to be in another session, so I couldn't attend. I know that you have talked about this report. It was during the COVID, but we think it's valid now as well. And the report is dividing the material into high-income countries and low- and middle-income countries. And in both settings, medical reasons are, of course, the most common reason to do non-operative treatment. And so is patient choice, as it should be, of course. Then I was a bit surprised to see that ability to pay did play a role in both settings, actually. Then there are three particular reasons that are just in the low and middle income countries, and that is the hospital resources, the socioeconomic status, and the age of the patients. So here we differ. Looking at the ability to pay, actually already in high-income countries like Australia and USA, elderly people has to forego care because of cost. Our view on aging is different in different cultures. And I tried to find some objectives on this, and it was very hard to find. But people were asked, how much a problem is the growing number of old people in your country? And it was in particular some high-income countries that actually saw this aging population as a big problem. We can understand that, but so it is. Then a WHO survey reported that 60% of the people asked did not think that older people were respected. And a bit surprisingly, the lowest level of respect were reported in high-income countries. So this really speaks against advanced aged, because that was a reason in low-income countries. But maybe the patient's own point of view could be affected by this in the society, because we also know that if she feels that she is a burden, she will perceive her life as less valuable, and she will be at risk of both depression and social isolation. And if you hold negative views about your own aging, then you do not recover as well from disability. So we need to stay positive, right? My thoughts on this is that an old person can be too modest in her communication with care providers if you don't feel like she is valuable enough to taken to healthcare. Then we will look at ourselves as surgeons, doctors, physicians, whatever. We want to do good for the patient, and we do not want to get in legal troubles. But we need also to acknowledge that medical paternalism exists. And then is when I find that the patient does not understand her own best, so I need to take a decision on behalf of her. And this can be a hard paternalism when we overrule a competent person. It can also be a soft paternalism when the patient is not fully competent and the physician make surrogate decision in the best interest of the patient. Keeping these two alternatives in mind, then there's a third one, and that's a very complex one. I had never heard about it before I read and prepared this presentation. It's disguised paternalism, where the physician's own personal values, including religious values, interfere with the clinical discussion. And you can read for yourself. I think it's as I said, complex, but really important for us to acknowledge that these things do happen in our mind, and it's not something that we might be aware of. We also need to understand the patient's course of life, because a person could be very close to the end when a hip fracture strikes her, and then of course it's the proper thing to do to provide her with non-surgical treatment and palliative care. But the problem is that it could look equally bad, but this person might have weeks or months or even more to live. And if we choose non-surgical treatment for her, we will shorten her life. But we can maybe, with surgical care and good geriatrician care, take her back on track again. Here I'm thankful to Julie Switzer, who provided me with a decision tree that they use in St. Paul, Minnesota. We cannot go into detail, but I think it's very important that you have such an algorithm that suits your organization, your legislation, whatever guides our decisions to use non-operative treatment in hip fracture patients. Then, what can we expect if we go for non-operative treatment? Of course, the literature is skewed by selection bias, but there are a good study from the Netherlands with very old patients who were able to either opt for themselves or their proxies opted for them to have either non-operative treatment or operative treatment in a shared decision model. 83% were dead within 30 months after non-operative treatment, 25 in the operative group. The proxies were asked about the quality of dying, and 51% said that it was good to almost perfect. My immediate thought is that half of them didn't think so. But treatment satisfaction was reported as high in both groups. Another paper from the Netherlands talked about a predictable short survival of a non-operative treatment. And this is one way to look at it. Another way to look at it is illustrated by a US-American paper with the same findings in the same population. They underlined that bringing the patients to surgery was associated with lower mortality, and their conclusion was to call for better quality in the care as a whole. And then the question is, what should that better care be? What should we demand from our healthcare system in order to make some structured algorithm for choosing non-operative treatment when suitable or wished for? Then I think we as orthopedic surgeons, every one of you from your professional view, need to disseminate the knowledge on hip fracture to other specialties and other caregivers. We all need to have the same vision of different care paths in order to give good information to family and patients. The care needs to be coherent and consistent during several weeks, and we need to control the pain. Maybe we should give a continuous nerve block. We need to avoid pressure ulcers, of course. There need to be a good general care. And we must remember that some people will also survive longer, so they will need a customized rehabilitation. It's not just palliative care here. So to conclude on this and allow a good discussion, I hope, there are large variations in countries, both between number treated non-operatively and the reasons for choosing non-operative treatment. And there are large variations in mortality in the studies depending on selection bias. I really think we need better tools for mapping the patient's course of life. I cannot understand how I should draw the true wishes out of a patient in an acute crisis. And I think we must better understand how our own personal values interfere with decisions. Thank you.
Thank you. We're open for questions. While we wait for hands and microphones, it's a triumph really to look back over 30 years and see a position where going to theatre was very uncertain. When anybody presented, it was very unclear, and it remains unclear in many countries. We're now to a point that the assumption in many hospitals is you've got a hip fracture, you're going to theatre now. It's going to happen now, and putting the brakes on and recognising when that might be inappropriate is often quite difficult to do in that fast track. And it's very easy to find the team resenting somebody who's saying, hang on, can we talk about it? Yes. Questions for Cecilia?
No, it's not possible. You must have some thoughts on this.
Well, Alistair gets a microphone.
Thanks very much. Very interesting talk. In my place of work in Edinburgh, it's virtually never discussed, the option of non-operative care for hip fracture patients. We had an American professor of surgery coming to give us a talk who said that they had a protocol where people from care homes who were not mobile were offered 2 weeks of analgesia, because it ultimately would make no difference, and reported reasonable satisfaction, with that. It may be the study that you mentioned there, but I just think it's quite an interesting culture thing that it's just not even on the agenda as a discussion, unless somebody is about to die in the next few days, they would nearly always get an operation in Edinburgh. I think it's 0.5% don't get an operation with hip fracture. I just wonder if you have a comment about that. Are we doing operations on people that we shouldn't be doing?
Yeah. It's very difficult to hear because the speakers are out in the... You have a question I heard?
Yeah, the simple issue I suppose I'm saying is that you're raising a very important issue that we may not need or shouldn't operate on everybody with hip fracture, but in some places like my centre, only 1 in 200 people don't get an operation for hip fracture, even if they're very disabled. And the only people that don't get an operation are people who are very close to death in the coming days. So it's just a comment on that, whether that's a big mistake that we're all making, or whether, you know, it needs more work before we understand that.
Okay, thank you. Now, I think it sounds like the Scandinavian way, that non-operative treatment is not an option. Everyone must have surgery regardless. And we get very stressed when family and patients are asking to have non-operative treatment. And then by talking to some of you during this meeting, there are countries where too many are taking to non-operative treatment. So we need to have some joint vision on where is the proper level. And of course, reasons like not being able to pay is heartbreaking, but it's a reality, of course. So I think if you work in a country when less than 2% are treated non-operatively, you should at least start a discussion with your colleagues that this might be an option, but how should we understand the patient's course of life? Because that's the core issue. And if you work in a country where more than 10% are treated non-operatively, then you definitely should talk with your hospital and try to sort this out, because you're disqualifying people who are helped by surgery. So we are the whole spectrum here in this room.
Yes, but for some families in those economies, that's the wrong thing for them to spend their money on. Yeah. Having surgery for granny when the rest of the family can't eat it, that's not necessarily the right thing to do. And even within the UK, we've got quite a lot of variation in non-operative rates between hospitals. There were interesting blips during COVID, and one hospital decided not to operate on very many people during COVID. But one of the best hospitals in the UK in terms of its mortality figures has a 5% non-op rate, and those patients go home. They have a different attitude. It's a very small hospital with a very personalized care, as opposed to some of us who are running industrial complexes, seeing several people on a daily basis. So these options are there.
Hi. My question would be, if someone needs a hip surgery for a broken hip and you don't operate, what do we do with that patient? That patient, I don't know, I mean, femoral nerve block perhaps, but then you're stuck with the patient in hospital or hospice. How do you actually get that patient out of a health facility? Thank you.
Great point.
Yeah, I had last one. I think it's also a challenge to have a healthcare organization, because we know that they will die within a short while, but is it 3 days, then she can stay with me at my acute orthopedic ward, but is it 3 weeks, I cannot have her there because other people need a bed. So some sort of step down or maybe step up to heaven facility is needed, and they should know about orthogeriatric care as well. So there's the challenge. What do you think?
Yes, and I think we've spent a lot of time this week talking about the surgical care of hip fracture, but talking about how to do non-surgical care is quite difficult, because Alistair rarely gets the opportunity. I rarely get the opportunity to do it, and I can work out what to do for individuals, but as the FFN, we probably ought to be thinking about writing some protocols for the management of pain in these people, because it's not analgesia, isn't going to be the right way to do it. Instant pain needs nerve blocks, it needs different approaches, and even palliative care teams are not very good at dealing with somebody who hurts when you try to move them. We're very good at doing that, because we do that all the time peri-op, but how do you make that into a long-term package? So I think developing an FFN protocol for non-operative management would be something we can try and do. He says, landing himself with more work before next year. Okay. Next question, go on.
It's a great talk, and what I want to know is that I always learned about quality of life, but today you told me a different terminology, quality of dying. How do you measure this?
How do I measure?
Quality of dying, because
It's not my study. I hope that someone from the Netherlands will be here to explain to us, but they have a very particular view on that, and all respect for that, and I don't know the method. Sorry.
Thank you.
But around the world, most of these people aren't dying. Most of these people are surviving without surgery. So this isn't about end-of-life care. This is much more complicated. Do you want to?
It's a validated instrument, that much I know, but...
Yes, thank you for a very thought-provoking presentation. You're talking about very complex decisions, which come with a lot of responsibility. And I think many health care workers or people who work with these sick people feel alone when deciding about life and death, because that's what we're talking about. Are you aware of any models where you can share responsibility and even get a better decision, maybe even ethical discussions or something like that, including relatives or something like that? I was just wondering, in my hospital we have something, patients who undergo cardiac angiography. If there is a finding, then the interventionist and the cardiologist have an ad hoc meeting and decide what to do. I mean, this is a different scenario, but something like that. Do you know?
Yeah, I think that every patient should have a comprehensive geriatric assessment when they arrive to hospital in best case scenario, and that would be the setting for such discussion. And again, the patient is in an acute crisis. I think such communication need to be done beforehand, but I totally agree, it should not be a one-person decision. It should be a shared decision-making with a multi-professional group.
Ian, one very quick last question.
It's not so much a question as an advert, really. Thank you very much for a brilliant talk. In response to what you said and what Anthony said, the intention is the FFN is going to try and develop some consensus statements on what a good approach to non-operative management should be. So if you're interested, please get in touch with me or with Lynn, and hopefully you'll see, we might even come back next year with some more information on that. So thank you very much.
Thank you.
Thank you.
Okay.
Okay.
Excellent. Thank you, Cecilia.
Thank you.
Just a quick reminder, you are also able to ask questions via the